This is actually a talk I'm very excited to hear. I have already introduced Hants, so I won't go through it again, but it's really very interesting to have different people's perspectives, interests, and skill sets all attacking the same question, and that is healthcare data. What do we do with it, and how do we use it? And I heard Hans talk. I invited him to speak to my vertically integrated program, my VIP class with Pam Ginex, where we have undergraduate students and nursing PhD students together, again, in an interdisciplinary team, bringing very different perspectives together to solve healthcare questions. And Hans gave an absolutely outstanding lecture looking at non-traditional data as it relates to the problems of healthcare. So I'm really looking forward to this talk, and with that, I will sit down. Thank you.
I'm very happy to be here. My presentation today is going to be on non-traditional data sources, kind of taking a step back from the EMR, EHR, our traditional data sources, and begin to think about what else is out there that we could use to enrich the existing clinical data that we do have, say, within Epic or Cerner, or one of the few selections that we do have. I'm going to share my slides with you all, so you could just take a quick snap of this if you want to have the slide deck. There's a whole bunch of links and resources that I'm going to be sharing, and figure this is probably just easier. So this should open up a Google slide deck, and then you should be able to see it. Hopefully not modify it, but that's okay. So I'll just leave this up for just a second. So there's going to be a lot of different resources and URLs. That's just easier to give you guys now than trying to track me down later. All right, so hopefully everyone that has wanted to get a photo of this has gotten it. I'm going to also just have my phone out so I don't get yelled at for time issues. So goals today, going to talk about non-traditional data sources, going to give you guys some examples, and then talk about the general process of how we might take existing clinical data and then enrich it with, say, data that is publicly available or other forms of private data that we might have access to through a third-party vendor. And if you want to, experience more about then the actual technical process, I'm going to be doing one of the afternoon sessions. We're going to do a live coding exercise. Going to share with you guys some code, and we're going to run through it. And if you've never played around with Python or a data language, it might be kind of interesting. So to begin and set the stage or the story here, right? We spend the majority of our lives not in a hospital, but in our homes. A great resource for you all, if you've never heard of it, it's called Gapminder. It's a very interesting experience. It's an online platform, kind of like a video ethnography, where you're able to jump around the world and see how patients live in their home environments. You could go, 6 out of 7 continents. They didn't have any researchers sign up from the 7th continent. But you could, go around and then navigate and see how these individuals live. What is in their kitchen? What is in their medical pantry? What does their common space look like? And it's a really good reminder around the complexities that a lot of us, live in, that normal care clinician, that us as care clinicians do not typically see. And to further emphasize this point, right, when we think about where we get the most bang for our buck, and we think about behavioral change and how do we actually change health outcomes, a very large percentage of what drives health is non-clinical factors or non-traditional healthcare care delivery factors, right? And that should make sense since we spend the majority of our time, hopefully 99.9% of our time outside of the white walls of a hospital and outdoors and in our neighborhood. So based on this then, right, we've been missing a lot when we look at what a traditional EMR system captures. Our medication management, our progress notes, lab values, et cetera. When what really is driving our health and wellness are a lot of these socioeconomic, financial factors, right, that drive that stress and that depression, or that drive the unhealthy eating habits that lead to, congestive heart failure, diabetes, et cetera. So what we or what I propose, and again, sort of what this talk then is really about, is about the enrichment of all of these non-traditional data sources that really drive and have a larger impact on our health care and on the health and well-being of us as patients and care providers. So from a data enrichment standpoint, and for those of you with the research hats on that have done, say, a mixed methods class, you'll probably be familiar with this term triangulation, that we want to be able to aggregate together, whether it's from a methodological standpoint or a data standpoint, a variety of different resources and perspectives to come to something that is more truthy. Sort of knowing that truth is, on a continuum, there is no right or wrong, true or false, but it's somewhere in the middle, and hopefully we could get there or get a little bit closer by combining together a variety of different sources. So that's really sort of what my whole talk here is about, that through the use of data triangulation, of incorporating in not just the traditional data that we find within our EMR system, but from a variety of other data sources, we could come to a more realistic version or a better understanding of what is driving health and what can we change or what can we do from an intervention perspective. So we've talked a little bit earlier about what I like to call like the cross-pollination of ideas, that I think healthcare can learn a lot, and we're still learning a lot by looking at what other industries do. So if we think about, say, for example, our credit scores and the types of data that a financial institution will take into account when coming up with our credit score, right? It's not just the bank information, it's also kind of, they might bring in public record data, other forms of spending habits, et cetera, to get a sense of, how much can this person be, trusted with, right? Or if we look at marketing with customer segmentation, another great example where maybe they've actually done too much here, right, with all of our targeted ads and, Amazon, Alexa, and, social media stuff, right, when we just look at our phone and we're just magically targeted something that we were speaking about with our friend 30 seconds ago. They've done a great job, right, of being able to understand our digital and non-digital identities by bringing in a rich variety of data sources to kind of come to a better sense of who we are. So that's my sort of main point here, is from a healthcare perspective, and we're beginning to see this, last 10, 20 years, it's gotten quite good, still a long way to go. But that's the way that we should be thinking about our care delivery system and our health informatic data, or what we're doing as health informaticists. We should not limit our thoughts around what's possible by only what we see within the EMR system. Because like I said, right, medication management, progress notes, lab values, admissions, et cetera, those only give us a very small slither of what's actually going on. So in terms of what we then do, or I'm going to talk just in generalities now about the sort of process of, all right, we have a problem and we want to sort of get some external data to enrich our understanding and to get a better sense of what's going on. These are kind of, I guess, 4 different levels or 4 different types of questions that you might want to start off with. So the first, what type of data do you want? So is it patient level, provider level, population level? Second question, geographic specificity. So is it street, block, or like a census block, zip code, county, state, et cetera? Third, what's the population, adults, children, specific disease cohort? And then number 4, if there's a specific type of data that you're then looking for, is it micro level down to something related to pathology and imaging, or is it something more so related to patient experience and qualitative data? So the world of data from a non-traditional standpoint is quite vast. Has anyone heard of the 2018 Open Government Act, out of curiosity? Okay, so a few people. So this was a very interesting catalyst where in 2018, federal mandate that all government agencies need to make a data dictionary publicly available of all of their data assets. So federal agencies have done quite well with this. State agencies are like getting there, and local agencies, I think, are still a very long ways away. But what this has given to us as researchers or as clinicians or as someone that wants to come up with an interesting data tool is access to a rich wealth of data across all of these government agencies that we have available to us. Now, the part of the issue though is once we sort of get that, it's not really sort of human readable, that it comes in this sort of type of JSON format where then you need to know how to understand it and read it. So the government, the government has different data portals and stuff like that to try and make it more accessible, but we still have a long way to go. So as an example here, if I were to ask this question to you all, I'd be kind of interested in what you would all think here. So which agency might we go to, and it might not be one of these here, if we wanted to get a full list of pharmacies and hospitals that exist in the US? Might we go to CDC, CMS.gov, Agency for Healthcare Quality and Research, or HRSA? Anyone want to shout out any ideas? Maybe it's one of these, maybe it's another agency. Any thoughts? CMS? All right, so the most up-to-date one is actually in the Department of Homeland Security. And if we think about that from the perspective of national infrastructure, right, and to keep our roads afloat, or that sounded weird, to keep our roads good, to be able to have access to healthcare in terms of a national disaster, public railroads, et cetera, right? From that perspective, it actually makes sense that the Department of Homeland Security would want to keep a pretty up-to-date list. Obviously, CMS does have their own versions, but sometimes they're only of CMS hospitals or hospitals that provide care to Medicare and Medicaid, and not necessarily for-profit and privately owned hospitals. And I'm going to touch on that point a little bit later. So a variety of different resources exist, and I'm going to want you guys to maybe go back to this slide once I'm done later on. So this is an interesting roadmap that a healthcare blogger put together that I thought was very interesting, runs this website called Out of Pocket. And what he did was he sort of mapped out a variety of different government agency-sponsored healthcare data resources. And then created sort of like a mapping around, all right, are you looking for adults or kids? Are you looking for national versus state level versus county level? And you could sort of use this guide to sort of walk through all of the different types of assets that might exist. And then within that last slide as well, there's a link that provides the various different URLs that you would then go to in order to access the various types of data there. So as an example, if you wanted to benchmark primary care, you would be able to sort of do that and go through this little Venn diagram. All right, so non-healthcare resources. So from a data enrichment perspective, kind of group these into three different buckets: behavioral, demographic, and geographic. So behavioral, we could think about social media activity, screen time, household utility consumption, subscription memberships, and there's a variety of different data sources that we could go to get these. So just to focus on one or two interesting ones here that might not be aware of, so the USDA Food Atlas, if we think about a lot of the chronic preventable illnesses that we're all working with, right, a lot of it can tie back to lifestyle. Food, sleep, healthy relationships, right? There's really 3 or 4 things that you need to do to live a healthy life, and food is one of them. So the USDA, they have something called the Food Research Atlas. It's one of 2 assets that they have that provides a variety of really interesting markers related to food availability, food scarcity, fast food density that you could use to, again, from a geographical or from a behavioral perspective, enrich a existing data set where you might not know a lot about where your patients are currently residing. Another really interesting resource here from Meta, Facebook, is called the Social Capital Atlas. And what this is providing us is 3 different markers for cohesiveness, economic connectiveness, and civic engagement. So this is all coming from Meta's Facebook platform. What they've done is they've, de-identified all of the relationships that exist. So however many, billion plus 2 billion users that they have on their platform, de-identified it, sort of geolocated, tagged it, and then made it publicly available. So for anyone that, say, is interested in better understanding mental behavioral health, and I think, post-COVID, COVID's been another theme, right? With all of the social isolation that's going on, this could be a really interesting resource for those that are intrigued in those types of topics. Next up, geographic. So one resource here that I want to share that's quite interesting, and for anyone that's a pediatrician or training to be a pediatrician, right? 2020, 2021, number one cause of death was gun-related violences. The FBI, they used to have an up-to-date data set, but they've kind of dismantled that, at least for right now. So there's a nonprofit, gunviolencearchive.org, which provides the most up-to-date. So they kind of aggregate together at the city and county level shootings, and then they classify them as adult or ped, whether it was a homicide, murder, a mass shooting event, et cetera. And then lastly, probably the biggest area, which we've seen a lot of resources just explode and vendors emerge, is related to demographic enrichment. So religious, ethnicity, race, age, sexual orientation, et cetera. So what we've seen kind of explode over the last, 18 to 24 months is a variety of these different data dashboards that focus on SDOH factors. And I think we've all sort of, as care providers here, have a pretty good understanding of why we should care about SDOH. So, but now the issue that we're running into is that it seems like, everyone is coming up with a new version or variation of this. So this example here, National Institute of Minority Health and Health Disparities, one of the lesser known agencies within the NINH, within NIH. So they have this thing called HD Pulse. Versus if we go to Agency for Healthcare Quality and Research, they also have another SDOH-related map that then focuses on broadband and poverty, but then has a lot of overlap with the other factors. Next up, CDC, they also have their own SDOH map that then, this social vulnerability index that's been around for a little while, but it's one of about a dozen different indexes that exist for SDOH. Google and Morehouse University, they partnered about 2-3 years ago at the very beginning of pandemic to also come up with their own SDOH tracker. United Health, or AmericanHealthRankings.org, which is a subsidiary of our big brother, United Health, they also have their own version of this. And I can go on and on and on, Microsoft, et cetera, Deloitte. So what this, though, has sort of then transitioned to is just this hodgepodge of there's actually kind of too many data resources out there with not enough clarity around who or where is the primary source of truth for a lot of this. The Agency for Healthcare Quality and Research, they put together a research study about 1 to 2 years ago that then tried to begin to aggregate some of these sources. So this is going to be provided to you all in this link again. They did this environmental scan and then mapped out all of the different SDOH resources and kind of just, tried to, say, all right, here's what we have at the county versus city versus zip code level, the different years covered, et cetera. And there was one researcher also at NYU that did something like this similar, but just for the state of New York with a specific focus on New York City. So for those of you that are interested in local population health, this will be another great resource where they identified about a little north of 60 different data sets that you could potentially look at. So all of this, right, is kind of overwhelming, and that's where this concept of the data swamp comes into play, that we have such a vast amount of resources, but a lot of it is overlapping. A lot of them are all based on the American Community Survey, ACS data from census, but then they relabel it and they reformat it. So that's then made it a lot more difficult for individuals like us then, right, to understand what is the right resource to use to actually go about this enrichment. So they've tried to solve this with a variety of different data hubs. So data.gov, I think CMS is just data.cms.gov. ArcGIS, Socrata is one of the other big vendors that we see across both federal and state level institutions, where they probably manage about 80 to 90% of all of the different data hubs that exist for open source data that are being driven by local, state, and federal government. And they all look something like this, where they'll have like a search bar. You'll be able to go through and filter by, say, what geographic area or type of zone are you looking for, the sort of newness of the data. But they're all pretty much based off of the census data. So if there's one thing that I would recommend if you are interested in pursuing more external data sources for enriching healthcare data, is to become very familiar with the ACS data set that's put out by the census. That is probably what powers the vast majority of the open source data sets that we currently see. So you probably get the most bang for your buck there. Now, in terms of what I'll call sort of like gray zones, and this is kind of the sort of fun, interesting stuff that I want to get more into, is using some of the same tools and technologies that marketers use. So if we think about, we sort of understand that our data is available for purchase, right? If you're a big tech company, you're going to purchase my data to figure out what you want to sell to me. So I think we could potentially use some of those same tactics. So there's this, and you guys can actually go in and check it out later, peopledatalabs.com. I looked up myself. It showed all of my social media connections. It showed how long I've been on certain services. It showed me sort of high-level spending habits, and it was quite accurate. And I was able to get all of that information for free through their preview. So all of this type of information is available to us. I think we just need to know how to use it. So if we look at some of these big companies, right, that have gotten into trouble in the past, Experian, Equifax, they've suffered some pretty big data breaches, right, and probably a lot of our social security numbers are now available. But having said that, they do have a lot of really meaningful data that can drive behavioral change. So I think it's like up to us to then figure out how to ethically incorporate some of this information in. We were talking earlier around anonymization, et cetera. I think that's extremely hard, extremely possible, or extremely hard to accomplish, especially when we're dealing with enriching our data with these other third-party sources. I think there needs to be like a larger conversation around, like what is the acceptable level of sharing, kind of a nationwide data usage agreement almost, where I think there's, different trends now where some people are more open to sharing their health data, but I'm not going to go too far down that soapbox. All right, so in terms of what we would then be looking for, again, another sort of little checklist here for you, if we're thinking about what types of requirements might we have for a data set that we want to use to enrich. First and foremost, a data dictionary. So a data dictionary, right, provides us the mapping of what are the columns or what are the variables or features that exist within this data set, how is the data set produced, and how is it maintained or managed. On the management and the maintain part, lineage and version. So being able to understand, how long has the data set been around, who's maintaining it, and is it going to be available to us in the future? Because if this data set's not being maintained and we grow to expect the, new fresh data coming from it, right, and we don't get that new data, we're going to be then looking for a new source. Ownership. One of the interesting parts with, we were talking about AI earlier, is with derivative works. And that's something that I think is a very interesting topic of discussion, specifically with data enrichment. So by derivatives, we mean, let's say that I'm going to combine together 3 to 4 different open source data sets, and maybe I'm going to use one proprietary data set. Well, if I then come up with a new fancy AI model that's able to, say, predict chronic kidney disease, AUC is 99%, and it's it's a legitimate model. Who then owns that model? Do I own it because I kind of did the intellectual grunt work, or does one of those data set developers or maintainers own it because it was technically their data? So from a legal perspective, I think we're coming into this like new gray area zone with machine learning and AI, because a lot of these models, right, you could sell them for a ton of money. But then you also want to attribute the different sources of what information did you use to then derive this new formula or to make this new model. So when you're looking at external data sets, always think about copyrights, and if there's a data usage agreement or if they speak to derivative works. And then finally, size and type of data. Is it something that's manageable for you and your skills, or say the availability of compute and resources that you have at hand? There's tons of really interesting data sets out there that might be petabytes in scale, though, that would cost a lot of money to store and save, and if you're going to be working in the data, it's likely going to expand. So having a sense of what's actually feasible for you. Then once you've actually gotten the information, you then are going to kind of go through this cyclical loop here of you're going to acquire it, there's going to be some form of transformation and cleaning, then integrate it into another source, probably do validation checks, and then there's going to be a maintenance period, and then the cycle is going to be rinse and repeat. So to go through the first step, assessment. So once you first get the data, some of the most important things that you're going to want to understand is, what does each row equate to? For my students that are here, sound like a soapbox, but in terms of being able to understand and interpret, does each row equate to a unique person, a unique encounter? Is it a stacked versus a wide data frame? Because if we don't understand those basics, we then won't be able to interpret and then later combine this data set with something else. Next up, data standardization. So the majority of the data sets that we find on the open web right now typically don't follow data standards that we might expect to see, whether it's like HL7 FHIR. So depending on how we're trying to enrich or merge our data, say, with existing healthcare data sets, right? Whether it's ICD, CPT, LOINC, HCPC, et cetera, the whole acronym soup, there might be some transformations there that need to get done. Next up, data integration. So the actual merging of the different data sets together. So 3 sort of high-level ways in which we could typically use to join data sets. First, a key-based approach where we have some common data elements that exist between our different tables, right? Maybe it's a zip code, maybe it's a patient identifier, something like that, that we could then use to align our different tables together. Second, spatial join. So if we're dealing with demographic or environmental data, geospatial data, whether it's sort of line point or some other variation, we'll be able to potentially do like a type of inner join where we find overlapping areas. And then last up, but probably most common, the sort of fuzzy matching, where we have different types of data sets where there isn't, say, a clear marker or variable, and then we need to do some form of inference to be able to kind of like here on the right-hand side, let's say if we have a variety of addresses that have been entered in by patients or care providers, right, they're not going to be in a standardized format, or if we have free text progress notes, that's probably a bad example because we could use a lot of NLP now to clean that up. But say that we have a variety of different addresses that look kind of messy, we could use a fuzzy matching approach to kind of use a best guess estimate of, all right, if there's a, close to a 90% character match, are we then okay with assuming that both of these things are equitable or roughly of the same meaning? So once we've then merged these things together, validation and looking for discrepancies. So one of the big issues that you'll sometimes run into with merging data sets is if you've merged data sets that, maybe one is a stacked data set, the other is a wide data stack, or a wide data set where you have some longitudinal data, then you have some other stuff that's non-longitudinal, and you don't conform or reformat it to be in the same shape, you're going to run into like issues where you started with, say, 10,000 rows, now you have 150,000 rows. Where did those other 50,000 rows come from? So this validation step, very important, kind of like the gut check step to make sure that what you've done actually makes sense. And then finally, maintenance. So data is alive, and I think one thing that I would emphasize here is that the data is living and the process is living. It's kind of like, hiring a new staff member, that it's not develop it and forget about it. That there's then a lot of maintenance, sort of IT debt that might go into maintaining one of these solutions that we then obviously need to be prepared for and thinking about when we're, embarking on an effort like this, when we're combining together different data sets. So as a preview then for what I'm going to chat about this afternoon after lunch, so we're going to work in Python. We're going to explore some data sets using a Python tool called a Jupyter Notebook. You don't need to have any coding exercise. I've already written all the code, and what we're going to do is we're going to go through it, answer some questions, and we're going to see how we would go about merging together 4 different data sets. So we're going to look at some transit data, and this is all national data. Looking at transit access, we're going to look at food availability from the USDA, a data set from the CDC, healthy places around diabetes prevalence, and then some census data that brings together fast food density, sort of bring them all together and learn how that looks and feels within a Python coding environment. So it'll be kind of a real world sort of walkthrough of how do we bring together some disparate resources, and you guys will then be able to walk away with some template code. Hopefully that should be enough for you to begin to explore and see how some of these technologies work with your own data that you might potentially have. So with that, thank you very much.
Thank you for your talk. You mentioned the ownership. This is a very interesting topic, and I agree about all your aspects. I want to ask your opinion. What do you think the patient, should patient own any of the IP? Because this data sort of belongs to patient. And will we reach at some point when the patient will be central part of the decision making and the data creation? Thank you.
Yeah, it's a great question. And I know that my students know this. So does anyone know who owns, or in what state? I'll tell you this part. There's only one state in the US where patients actually own their own data. Only one state out of the 50 states and all of our territories. Anyone want to take a guess at what state that is? Yeah. Nope, it's not. Nope. 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 Rhode Island. Yeah. So Rhode Island is the only state in the U.S. as of maybe 2-3 years ago. I haven't looked it up again since, but I'd be surprised if it's changed, where patients actually own their own data. The vast majority, right, is then owned by the EMR companies or by the care providers within specific states. Yeah, I for sure think that we should own our own data, but then it should probably be managed by other providers and systems and stuff like that. But I think that there needs to be more transparency then around from, say, me being a consumer of healthcare, like is my data then being sold to a pharma company to develop the new billion-dollar drug? Because if so, I would like $5, maybe $10. So I think we've seen that there is a lot of utility in healthcare data that could be commercialized for a variety of different things. And I think, yeah, just because of that national conversation, there probably should be more transparency. But yeah, I do find it fascinating, though, that it's only one state, and I don't know the historical background. It would be kind of interesting to look that up around how did Rhode Island actually get away with that negotiation. Because, yeah, Texas, California, New York, right, where we have the highest density of populace, it's Epic or Cerner, or it's the state of California, the Department of Health in New York. Yeah, good question. Any other questions? Yeah.
So, interesting insights have you found by combining different data sources with healthcare?
Yeah, so one of the most interesting things that I've been focusing on over the last year or two now is specifically with SDOH, and that SDOH is actually not very predictive of health outcomes when you're looking at publicly available SDOH data. that there's been a number of studies now that have been published that have looked at, say, aggregates of census level data that have, that then these SDOH vendors are selling to large health systems to try and, say, hey, we're going to predict poverty, or we're going to predict lack of food access or lack of transportation. And the data that's being currently sold and then utilized by healthcare systems is not granular enough. So when we're looking at the outcomes of how predictive some of these SDOH solutions are, they're not actually that great.
What are they looking at census tract level, or?
So what they're selling is not census tract level, or it's like aggregate. So what they're sort of seeing is, right, that like if you get to an aggregate level where you go above a census block or you go above a street, it's too generalized. So by just looking at a city, a county, a town, that's not good enough to actually make use out of SDOH data. And I think that's then an interesting complication, right? Because then from a patient privacy perspective, how are you then supposed to maintain that if you're dealing with just one street block? And then you're dealing with, say, a condition, say, an ICD code like HIV, and there's only one person on that block with HIV. Pretty easy to then re-identify that individual. So I think that's like been kind of interesting with all the hype around SDOH, but we haven't really figured out how to do a lot of meaningful work with it yet.
What about at the hospital level records where you have access to identify patient data by exact address? Are people looking within those populations to predict outcomes and behavior?
Yeah, so I guess one of my other soapboxes here is I think we need to utilize social workers more. With their knowledge and their experience and their ability, right, to connect to the local community, that they're the ones that understand what the local resources are. That us as doctors or nurses or PTs or RTs or et cetera, we don't necessarily know where the food pantries are or where they would go to get more transit. So I think making and bringing in this more of an interdisciplinary team approach with a higher emphasis on social workers for all of the long-term outpatient care management that needs to happen, that they need to be, more involved in some of those decisions. Yeah. Yeah, question?
I was going to hold my comments till later, but since I'm a professor in the School of Social Welfare here, I have to respond. Yeah, thank you for the comment about interdisciplinary practice, and totally appreciate the context for this around social determinants of health. I just wanted to make a comment in mentioning SDOH, and the complications about extracting data around SDOH has been a big issue. We recently completed a study out of a larger integrated behavioral health trial about what it means to co-locate behavioral health providers on teams and how collaborative care models can leverage access to data. One of our take-home points was that in areas where there's high levels of social deprivation measured by the Social Deprivation Index, practices and sites were less likely to document things that are associated with stigma, like alcohol use. And their training on the ground in what to document, how to document in EHR, things that are difficult for doctors, for all of us, to ask about in these clinical encounters was a big take-home point. Therefore, we learned that when we go back and then try to extract data about the comorbidities of patients, particularly around things with stigma like substance abuse, we couldn't leverage anything meaningful out of that data because of the failure to document them in the first place in this one study.
Yeah.
So I don't know if you had a thought, or if other people, we could have discussion later around who documents, how does it get documented. I think this sort of came up as an important question. So thank you for that.
Yeah, and I think that's been the big confusion. So the big informatics organization, American Medical Informatics Association, or MIA, I guess? Yeah, so they had produced a data report, a white paper this last year that focused on SDOH. And in that, they gave some really interesting statistics that one of the key concerns right now is that they don't know who's supposed to document, because no one's been really assigned to, because there's so many different types of scenarios, right? Whether it's in the ED, is there a social worker available? Probably not. Does it then land on the nurse or on the physician doing that, first initial assessment? Who knows? And then even once you maybe have identified who that person is, how do you then actually collect that information in a meaningful way? Like I think Stony Brook's going to be required to collect 2 new additional metrics on SDOH, like housing and food scarcity or something like that, starting in 2025 or 2026. And that's an issue that I believe that we're still working through. Like, how are we going to collect that information? Who's going to collect it, and where is it going to live? So yeah, it's a great question.
I will take my moment here to say everyone's going to have lunch as soon as I shut up. But I did want to mention, it's very interesting, if you look at social determinants of health and you look at education, education is strongly correlated with health outcomes. And nowhere do we document education in the chart, nowhere. It's impossible to find it. And there's no formal way that one can go back and look at a population with such a simple question. It's a 1 or 2 word answer. We don't have it. Thank you for that absolutely outstanding talk. I think it's time for lunch. Thanks.
Thank you.